I am Dr. Miguel Mantaring from the Health Promotion and Communication Service of the Department of Health, and I will be moderating today's session. In behalf of the PCP and the DOH, I would like to extend my thanks to all the attendees who have joined us for our regular webinar discussions throughout the past months, for maintaining this level of scientific discourse and constructive criticism in the efforts of the department in curbing the pandemic. So we really hope to provide more avenues and platforms which will equip us as health practitioners with the knowledge to help in providing the best care for our patients, whether it be in a community or hospital setting. So today, in partnership with the Philippine Society for Microbiologic and Infectious Disease and the Philippine Hospital Infection Control Society, we will be tackling a very relevant topic for us health workers. As has been reported both locally and internationally, health workers have been at the forefront of this fight against the pandemic, and we have lost a number of our colleagues to the virus. How do we activate and mobilize our local health systems into curbing the clusters of infections in health facilities after a case is identified among our ranks? And what can we learn from the practices of hospitals who were faced with similar situations? Today's session will cover outbreak investigation and management in hospitals and specialized healthcare institutions. So as for the general objective of our session today, it is to discuss the proper approach to conducting outbreak investigation and management in hospitals and specialized care institutions. Specifically, starting from a national perspective, we aim to provide a situationer on the status of COVID-related healthcare worker infections in the Philippines, to enumerate the national government strategies in addressing healthcare worker-related infections. And zooming into our representative private and government hospitals, we aim to enumerate the important steps on detection, case finding, and confirmation of the outbreak, to elucidate on the appropriate measures of handling the outbreak, including the mitigation of its seriousness and related consequences, to discuss the proper infection control measures to prevent its spread, and to provide the framework on how it's managed to prevent the reoccurrence of the problem. So today we are very privileged to have with us three very distinguished speakers from the Department of Health and from the different national and public hospitals within our country. So our first speaker for today is Dr. Napoleon L. Arevalo. He attained his medical degree in the Manila Central University and master's in public health from the University of the Philippines, Manila. He has been working as an executive in the Department of Health since 2013, beginning his executive career with the DOH Regional Office or Center for Health Development of the Bicol region as its Assistant Regional Director and Director for 5 years. In 2018, he became the Director of the Disease Prevention and Control Bureau of the Department of Health, a position which he holds still present. So ladies and gentlemen, Dr. Napoleon Arevalo. Our second speaker is Dr. Janice C. Kawili. She attained her medical degree at the University of the Philippines and took her residency and clinical fellowship training in infectious diseases at the UP-PGH. She has a research fellowship in Emerging Infectious Diseases International Laboratory Fellowship, Mycobacteriology Laboratory Branch, at the Division of TB Elimination at the National Center for HIV, STD, and TB Prevention at the Center for Disease Control, Atlanta, Georgia, and HIV Fellowship at the Whale Medical College of Cornell University. And now concurrently holds multiple positions as the head of the Center for Travel and Tropical Medicine, HIV Treatment Hub, and the chief of the Section of Infectious Diseases, Department of Medicine, as well as the head of the Infection Prevention and Control Department of the Makati Medical Center. So, ladies and gentlemen, Dr. Janice Kawili. And for our third speaker is Dr. Bernadette Celudo. She obtained her master's in public health at the UP Open University. She is currently a fellow of the Philippine Society for Microbiologic and Infectious Diseases and former president of the Philippine Hospital Infection Control Society. She is a full-time medical specialist 4 of the National Center for Mental Health, the NCMH Chair of Adult Infectious Diseases Section, the chairperson of the NCMH Infection Prevention Control Committee, and the National Center for Mental Health COVID-19 team leader. So ladies and gentlemen, Dr. Bernadette Celudo. So to begin our discussions for today, can we now call on Director Napoleon Arevalo to kick off our session for today. Director Nap.
Thank you very much, Dr. Magtaring. Mantaring, I'm sorry. And good morning, everyone. We are grateful for this conference to the PCP. And in behalf of USEC, Mirna Sikabotahe, we will be presenting or sharing with you our experiences in the healthcare facility assessment conducted jointly by the WHO, by the Department of Health, and by the and May 29 and 30. And
Hello, Director Nap. So it seems like we're experiencing some technical difficulty on our end. Uh, a few minutes lang po. No? Sorry, we'd like to apologize to all our participants.
the next top 5 healthcare facilities which have been reporting cases of COVID-19 among healthcare workers. So if I can have the first slide, please, Doc. So as a backgrounder, health workers are a vulnerable population for COVID-19 infection. And prevention of healthcare workers' infection is of urgent priority since healthcare worker infection will damage the capacity to care not only for COVID-19 cases, but people with other diseases. It is also important to note that healthcare worker can be infected while taking care of the COVID-19 cases in hospitals, or they can be infected between or among the colleagues at the healthcare facilities and in the community as well. This makes the prevention of healthcare workers' infection difficult. Also, there is an accumulating evidence suggesting that pre-symptomatic and potentially asymptomatic transmission can occur, making prevention of transmission even more difficult. So as of May 30, 2020, 15% of reported COVID-19 cases are healthcare workers. Although there was an observation that there's a decreasing trend of infection among healthcare workers, the laboratory backlogs, also the delayed reports limit the data interpretation. So there's still ongoing reports of infection, and also there are hospitals that has reported clustering of cases. So these are the characteristics or demography of reported healthcare worker infections. Majority of the healthcare workers are in the age group of 25 to 54 years old. Some are 60 years old and above, while the oldest is at 87 years old. The top 2 healthcare worker professions affected are the nurses and the physicians, and the case fatality rate, which is 32 among the reported healthcare worker infected as of May 30, 2020 is at 1%. This is the healthcare workers affected by COVID-19 as of May 30. As you can see, there are 937 nurses affected with 4 deaths and physicians at 702 with 26 deaths. So mas maraming namatay ng mga physicians while taking care of our COVID-19 patients. Next, please. So this is the summary of observations which was gathered and consolidated by the WHO, the DOH Epidemiology Bureau, and the Metro Manila CHD, while they did their initial visit on March 11. And the following are the summary of observations in the 3 health facilities which were prioritized as there were quite a number of healthcare workers affected with COVID-19. The good observations is that the surveillance system in these hospitals were in place or are in place, so much so that they were able to report the occurrence in their respective health facilities. The contact tracing is activated, and there is a provision of quarantine facilities for healthcare workers. But really, we would like to see also later in the recommendations the accommodation of the healthcare workers in line of duty. The following are the IPC measures consistently observed. The IPC team for COVID-19 were designated, dedicated to do the IPC, to monitor the infection prevention control in the health facility, were trained on IPC. The PPEs are available as per level classification, and some said that they have stable supply of PPEs, not only coming from the Department of Health, likewise from their own procurement, as well as donations. There are dedicated donning and doffing areas, but we have to take a look at this also later in the recommendations, and also hygiene areas are available. The good practices which were observed or noted is that there is a sufficient human resource from all 3 hospitals, and that the isolation and quarantine specified hospital zoning for high to low risk areas, which is currently being implemented. As I've said, there's complete set and sufficient PPEs available. They also noted that there is updated inventory of PPEs, which is very important so that they can replenish before it runs out. Medicine also are secured, and likewise equipment that are critical. PPEs are readily available at critical areas such as triage and isolation, and some are really observing the optimum use of PPEs. Like if there are barriers, physical barriers in the triage area, they usually optimize the use of PPEs, that they only use not more than the mask, the surgical mask and the gloves. But those without barriers, they don complete PPEs. In the infection prevention and control practices, all hospitals had IPC manual. The wards and other critical areas are manned by staff trained on IPC. And they established a 24-hour on-call infection control committee to address suspected and confirmed cases of COVID-19 within the hospital premises, served a vital role in battling the disease. So ito po yung nakatulong in terms of controlling the infection in their respective areas. To continue in the triage and assessment, there was a signage, and they really strictly implement the no face mask, no entry policy. Temperature screening is being implemented at all entry points. Ingress and egress segregated and monitored, and that there's transparent barriers in place between staff and patients in registration or in administrative areas. So even if they are not directly caring for their COVID-19 patients, they have established their administrative and engineering controls. On clinical management, the hospitals are following the clinical management guidelines for COVID-19, and they have their medical specialists and consultants. They also have a very good coordination with the DOH, the RITM for the testing, and the Philippine Red Cross. The transfer and referral system, we took note that these hospitals have licensed ambulance dedicated for transfer to COVID-19 patients. Should there be a need to transfer them to the dedicated or to the COVID-19 hospitals which were designated as such. Other observations is that there's application for licensing of their own COVID-19 testing laboratory that we also need to fast track for them to be able to help us out in the expansion of the testing capacity of the country and the participation of these hospitals to the Philippine Solidarity Trial for COVID-19 treatment. Next, please. So there are, of course, gaps and issues which were identified during the initial visit, that even if there was adequate or sufficient human resource manning the hospital, both for COVID and non-COVID, there was no written policy for addressing COVID-19 confirmed healthcare workers' concerns. So this is actually a very important component in the assessment of the hospitals for them to be able to provide a very good flow of communication, as well as addressing the concerns of those healthcare workers infected with COVID-19. For the isolation and quarantine, although there is a designated space or there are designated quarantine areas, there are no visible signages indicating these specific areas. And also, while they are implementing hospital zoning, there are no visible markers for the healthcare workers, as well as the patients can appropriately follow. For the infection prevention and control practices, there was an observation that the waste management protocol and the memorandum of agreement with LGUs for waste collection and disposal should be updated. In the earlier days of the lockdown or the ECQ, there were problems or concerns on the waste management of the hospital. So they should be improved, and they should be updated, and that they should ensure that there should be no gap in the management, as well as in the collection and disposal of the healthcare, hospital healthcare waste. And then for the triage and assessment, there's lack of signage regarding cough etiquette, physical distancing, and hand washing. We think, or we would like to underscore this as there will be no more the same environment, and we will be looking forward for the new normal, that this should be the what they call this, the lifestyle or the daily habit, that the healthcare workers and the ones going to the hospital, be patients or support group, should be practicing. Then there are limited hand washing areas and lack of hand hygiene installations. There was also no documentation on disinfection and sanitation procedure of hospital areas. This is very important. There should be an announcement or a frequency of the periodic disinfection or the sanitation procedures in the hospital. For the clinical management, there was lack of directional signage to guide patients to appropriate hospital areas. Although this is very minor, but this is very important, equally important. Was limited hospital contingency planning during disasters and outbreaks, and there was no written policy in surge situations like pandemics and outbreaks. So I think it is imperative for all hospitals to have these contingency plans, as well as the surge capacity plans, because we are now in the new normal, and we also would like to prepare for any eventuality, not only outbreaks or pandemics, but likewise, should there be a need for the calamities and disasters that we usually experience in the Philippines. Other observations that they have to improve the cascade of communication and implementation of policies. True that they have received interim guidelines from the Department of Health. There's numerous of it, but this should be communicated well, and there should be monitoring as well as assessment if these policies were understood and being implemented well in their healthcare facilities. There was lack of IEC materials on IPC measures at conspicuous areas. So the recommendations were as follows, although I have I have already mentioned some. These are the recommendations raised by the WHO and the CHD after the visit. One is that the hospital should ensure proper risk assessment and monitoring of staff. So we have a cascaded guidelines on this, wherein the Department of Health uh, has circulated a department circular adopting the healthcare worker risk assessment in the healthcare facilities. We have to scale up training on IPC for all healthcare workers. Well, the WHO, in collaboration with UNICEF and the Department of Health, has been cascading the IPC training, and as of May 15, there are a total of 3,146 participation in the IPC webinar for home and community settings, while about 4,500 participated in the IPC training for frontline health worker in facility and hospital. Also, there should be a consistent monitoring of adherence to IPC measures, like the body system for donning and doffing. Later, we will share with you the donning and doffing practices by the Chinese specialist who came over to the Philippines to assist us in the not only in the IPC but in the management of the pandemic as well. There should be rational use of PPEs. We do not recommend the use of level 4 PPEs for non-COVID areas, meaning yung complete set ba. There should be risk-based use of PPEs. The Department of Health issued a guidance on what PPEs to be used in different areas, like that. We cascaded the packages of PPEs appropriate to each level, like in the triage area, in the isolation wards, at the ICU, at the emergency room, quarantine facilities, etc. Even to include the transport of patients, collection of specimen, and among others. While zoning is not clear for some places, there should be really a clear guide for healthcare workers and patients or companions going to the hospital on the hospital zoning for their appropriate adherence or follow for them to follow. There should be increased availability of alcohol-based hand rub. There is a need to have alcohol-based hand rub at doffing station for staff, nurses station, and other places so that healthcare worker can practice frequent and hand hygiene. Ang na-observe din, while in doffing, there should be consistent application or alcohol hand rubs while taking off every piece of the PPEs when one is doffing the PPEs. Then misting station is set at doffing space and at entrance and exit of hospital, which is not recommended because this might pose a risk to the health of the healthcare workers. So in last week, the Department of Health deployed a rapid response team, which is composed of the DOH, Disease Prevention and Control Bureau, the NCR, Metro Manila, CHD, and the WHO for us to have a follow-through of the assessment where the actions or where the recommendations implemented by the hospitals, and we would like to also further review the surveillance and contact tracing mechanisms which were recommended in the earlier visit, and also to guide the hospitals on the IPC self-assessment tool, because the Department of Health adopted the WHO IPC self-assessment, And we further enhance this by harmonizing the ones that we got from CDC, as well as that that we incorporated also the ones which is on the pipeline prepared by the Health Facility Development Bureau. And then we would like to provide further policies that would enhance IPC in the workplace as references and tools, and a co-development of quality improvement plan from the end of the health facility as they observe the gaps and the items in the tool that need improvement, and that at the end of the rapid response team is a technical assistance plan based on the quality improvement plan made by the health facilities. So this is a Department Circular number 2020-0106. This is the use of WHO interim guidelines for health workers, exposure risk assessment, and management in the context of COVID-19 virus. This is already available in the DOH website. You can all access this and utilize this in your exposure risk assessment of your healthcare workers. This is the harmonized DOH, Health Facility Development Bureau, the WHO, the CDC IPC tool that contains the administrative system on COVID-19, on communication, reporting, the infection prevention control practices, screening, triage, and isolation, the environmental controls, the clinical management of suspected and confirmed COVID-19 cases, the transport of suspected and confirmed patients. Yeah, and we would gladly share this to you for you to be able to conduct your self-assessment or periodic self-assessment and address the gaps that you observe during the self-assessment, and probably do a quality improvement plan, and those that is needing technical assistance from the WHO and Department of Health be forwarded to us so that we can address such concerns to prevent further spread of the disease among healthcare workers. So the exit conference that we conducted with hospital management is that they concur and acknowledge the observation, and that they will be implementing the quality improvement plan that they have formulated, and that the Department of Health, the WHO, and the CHD, NCR should follow through the concurred and acknowledged tool or findings, and that the management should pursue the implementation of the recommended actions to be taken. So for the ways forward, we are recommending the strict compliance to IPC standards and guidelines. These are quite a number of department memoranda issued by the Department of Health, which should be in the healthcare facilities, in our Center for Health Development, from level 3 hospital down to the infirmaries and down to the primary care centers, to guide them in the infection prevention and control. So these are all available in the DOH website. So may we enjoin everyone to access this, and these are all interim. So we are to update this from time to time as we continue assessing the periodic assessment of this IPC at all levels. So Marami po yan, and we would like you to have a copy or access it from our website. Next, please. So number 2, there should be periodic healthcare facility assessment. So we've said that we can, as soon as the tool is finalized, the harmonized tool is finalized, we will be cascading this to all hospitals for you to do the periodic healthcare facility assessment on your own. You might be not needing the presence of WHO as well as the DOH. You should be able to conduct it yourselves. And should there be technical assistance that are required, then you can forward the quality improvement plan to the Department of Health, so that at the end of the Department of Health, we can do also a technical assistance plan together with the WHO. Then we have to further the staff IPC capacitation on donning and doffing, and doon sa shinare ng Chinese specialists when they visited, they recommended the doffing areas should be ideally divided into 3 tiers or levels to reduce risk of contaminating clean area. This was the recommendation of a 3 areas, quote unquote, from the end of the Chinese specialist who came over. Yung level 1, the removal of the outer layer, the hazmat, the bunny suits, yung coveralls. But ang sinasabi nila that they, in every doffing of the piece of every piece of PPEs, the health worker should practice the alcohol rub. Kasi ang napansin nila sa visit, hindi ito nagagawa piece by piece. When you remove your hazmat, hand rub ka. Mag-remove ka ng yung gloves, hand rub ka ulit. So that's level 1, removal of the outer layer. The level 2, the removal of inner layers and mask. And then the level 3 is a change of uniform. So the uniform and other materials which entered the contaminated area should not go out of the doffing area to clean areas. That's why, if it's feasible, they were recommending na 3 yung areas in the doffing of the PPEs para mas ma-limit natin or talagang ma-reduce natin yung pagkalat, whether if ever your PPEs are potentially contaminated. Next, please. Then the strict implementation of healthcare worker risk assessment. So meron tayong Department Circular number 2020-0106 na pinakita ko na sa inyo in a flash. This is the use of the WHO interim guidelines for healthcare workers exposure risk assessment and management. Ang sinasabi natin dito sa exposure risk assessment, na sana we do the risk assessment and monitoring of healthcare workers. We should do active screening before every shift of the healthcare workers to include those who are not in charge of direct care to patients, because we observed that there were administrative staff which were infected, and we cannot discount the possible spread sa hospital mismo, or if this infection were or has occurred in the community. So we also recommend that there should be active screening, not only of the healthcare workers, but of the ones who are coming to the hospital, whether non-health workers or health workers. Further, for the hospital to organize the structure for COVID-19 response. So ang tinitignan natin that a COVID-19 response team be installed, and that the chief of hospital or the medical director should be on top of this. Yung mga napuntahan natin, meron silang IPC committee, but there was no COVID-19 response team that would oversee and yung titingnan yung pangkalahatang preparasyon and the whole operations of the COVID-19 response. And also the creation of an IPC wherein the members are well trained on IPC. So a minimum of a nurse and a doctor comprising the infection prevention control team. In the case investigation and contact tracing, in most areas that we visited, we took note that the ones in charge of the IPC is likewise a surveillance officer, which makes it a little bit difficult to do the case investigation and contact tracing side by side the ensuring the infection prevention and control. So we recommend that there's a dedicated trained surveillance officer to do the case investigation and contact tracing. Also, we have observed that yung case investigation and contact tracing were quite or was temporized while they are awaiting for the result of the test. We say that we do not wait for the result of the test, but we immediately do the case investigation and contact tracing, and that the surveillance officer and the IPC team must recommend to the chair of the COVID-19 response team of the hospital the appropriate measures, like the healthcare workers be quarantined where? At home, in a quarantine facility, or should be admitted in the hospital depending on the symptomatology, as well as there should be somebody monitoring them, whether even coming from the hospital itself. You know, probably the surveillance officer should continue monitoring the healthcare workers who are sick outside the healthcare facility. Like if the healthcare workers are quarantined at home, they have to do the daily monitoring by perhaps calling them and making sure that the daily monitoring is being logged, so that we know if the healthcare worker at home or in the quarantine facility be transferred to a hospital depending on their symptomatology. The risk assessment and monitoring of healthcare workers, as I've said earlier, there should be active screening and monitoring and reporting. The IPC practice, we should strictly adhere to the IPC protocols. Napakarami nung ating mga nirelease na mga department circular, department memoranda, and lahat ng ito, even if these are in a piecemeal manner, in these department circulars and memoranda, the IPC is reinforced. Kaya mas maganda na binabasa lahat natin yung mga in-issue, because in every policy that we release, the IPC protocol is being reiterated. And in the IPC practice, the administrative and engineering controls should also be implemented. So the work arrangements, your hand washing facilities, the availability of your PPEs. We also, outside the IPC practice, in the care of our healthcare workers who are sick, it is important to have the lines, the hotline from the end of the COVID-19 response team in the hospital, for us to be able to address also the concerns of our healthcare workers who are sick in their homes, in quarantine facilities, or in the hospitals. It is important also to provide support, the mental health and psychosocial support. That is why we also would like that the hospital has a trained mental health and psychosocial support provider. Or better yet, we can you should avail or access the hotline coming from or established by the National Center for Mental Health. Later, we will be providing you with numbers of the National Center for Mental Health, usap tayo for the mental health and psychosocial support services. To add, there are NGOs like the In Touch, which is also catering for the mental health and psychosocial support of healthcare workers, for the frontline workers who are active, as well as those who are sick in the homes or in quarantine facilities or in the hospitals. Other recommendations, like on disinfection, yung misting and spraying with people with disinfectants with chloride dioxide, we should underscore that this does not kill the virus inside the body, and this can pose risk to the health. Lalo na yung may mga allergy, yung may mga asthma, baka matrigger yung kanilang asthmatic attacks and might cause also lung injury. So we do not recommend misting or spraying people with disinfectant. Yung nirecommend ng Chinese specialist, yung foot bath, parang they would like to recommend it that its use is when moving from highly infectious area to lower infectious area. Like for example, from the doping area to clean area, or from the hospital to the outside. Our practice now, kung makikita natin, ang practice natin, ang ating foot bath sa labas bago pumasok. But our specialists, the Chinese specialists recommended na kung pwede, mas maganda siguro if our foot bath should be coming from the highly infectious area to the less infectious area. So that was the recommendation. So that was my last slide. Thank you very much for your kind attention. Perhaps the Yusek Mirna, if there are additionals, maybe we can have a few words from Yusek Kabutahe.
Thank you, Director Arevalo po. So this morning, we are also privileged to be joined by the Undersecretary of Health, Dr. Mirna Kabutahe of the Public Health Services team of the Department of Health. So ma'am, if you have any words po, we would greatly appreciate po during this time.
Thank you very much for this interaction. Nasabi na lahat ni Dr. Arevalo. What is important is really the non-pharmaceutical intervention. While we are concentrating on the treatment, the infection control, the non-pharmaceutical intervention of social distancing is important. There are reports that health workers do not observe social distancing when they eat, and then there should be a entry and an exit for those who are catering to COVID patients and for non-COVID patients, and the entry and the exit for our admin. This is part of engineering control. And while Dr. Arevalo mentioned that disinfection is not recommended, yung misting and spraying, what has so that we have used for what is available, di ba? Meron tayong spray tents ngayon. This is recommended before mag donning and doffing. So when you put on the PPEs, that's the time na nag-spray, because you spray on the material, not on the person. So yun lang. It was pretty covered very well by Dr. Arevalo. Maraming salamat po.
Thank you po, Yusek Kabutahe. Okay. So to move on with our discussions and to zoom into the perspective of the best practices done in the different hospitals in the Philippines, I'd like to call on our second speaker, Dr. Janice Kawili from the Makati Medical Center. Dr. Kawili.
Thank you, Migo. I will now share my slides. Migo, are you able to see my slides?
Yes, Dr. Kawili, we can see it.
Thank you very much. Good morning, everyone. I would like to thank PCP and the webinar organizers for inviting me today to discuss our experience at Makati Medical Center on management of COVID-19 among healthcare workers. I would like to disclose that I am employed at Makati Medical Center as head of the Infection Prevention and Control Department, and I developed most of the algorithms that I will be presenting today. Our hospital is located in the central business district of Makati and has been at the forefront of the COVID-19 response since the start of the pandemic. Makati City caters to several business establishments, employing foreigners and travelers, and it was inevitable for our hospital to see a person under investigation for COVID-19. Very early on, we developed processes for triage, testing, admission, and management of these patients. And it seemed that we were ready to handle these cases when the first PUI arrived at our emergency department, or ED, last January 22, 2020. Fast forward to 4 months later, Makati Medical Center has seen a total of 5,825 suspect COVID-19 cases and tested 80% of these patients using RT-PCR for SARS-CoV-2. As of May 29, 2020, we have seen 527 confirmed COVID-19 cases in our hospital. Our hospital experienced a surge of patients with acute respiratory failure in March. We admitted the first case of confirmed COVID-19 on March 6th, and within the next few weeks, our ED was screening almost 100 patients daily for COVID-19. Each department and unit in the hospital was mobilized to respond to the increasing number of admissions. We implemented very early on a screening and triage algorithm at the ED to identify COVID-19 suspects who will be admitted in the hospital. We identified isolation areas dedicated for suspected cases. We trained our healthcare workers on proper infection control procedures and use of PPE, and developed processes for all patient care areas to minimize exposure of our healthcare workers to COVID-19. By mid-March, all healthcare workers in the hospital were required to wear a face mask. The infection prevention and control team also updated procedures for contact tracing among healthcare workers who will be exposed to patients with COVID-19. On March 5, the Department of Health identified the first case of locally transmitted COVID-19 infection in a 62-year-old male who had no travel history outside of the Philippines and was admitted for severe pneumonia in a private tertiary hospital. This event was the basis for broadening the screening algorithm being used at the MMC for COVID-19. Pneumonia was included as an indication for COVID-19 testing starting March 6, 2020. We conducted pneumonia rounds among inpatients to determine if any of them had pneumonia and COVID-19 infection. We identified 12 patients and all were tested for SARS-CoV-2. These patients were placed in isolation pending the results of COVID-19 testing. Of the 12 patients with pneumonia, 3 were confirmed to have COVID-19. We immediately conducted contact tracing among all healthcare workers who cared for the patients in the hospital. Among those exposed, 2 healthcare workers were found to be infected. They were the first healthcare workers who tested positive for SARS-CoV-2 at Makati Medical Center. A spike of healthcare worker infection occurred during the first 2 weeks of April. At that time, we also identified several clusters of healthcare worker infections in the hospital. Since March 10, 2020, we identified a total of 1,864 healthcare workers with exposure to COVID-19. Almost half were from the nursing service, more than a fifth were doctors, a fifth were auxiliary staff that included facilities, janitorial and housekeeping staff, and security guards, and the remainder were diagnostic centers and the pharmacy. 1,551 or 83% of exposed staff were tested using RT-PCR for SARS-CoV-2. Our goal for contact tracing is to immediately identify and isolate each case to stop transmission within a unit. Clustering of cases in a unit required broader testing, and this graph illustrates the increased testing conducted in response to the spike of cases in April. Mass testing of healthcare workers in a unit with several infected healthcare workers was key to controlling outbreaks in our hospital. There are fewer healthcare worker infections this May, and most of the identified cases were isolated such that transmission was not sustained. The Infection Prevention and Control Department receives the following reports related to COVID-19. Patient case information forms of all cases swabbed for RT-PCR for SARS-CoV-2, all positive RT-PCR results from RITM and from MMC Molecular Laboratory. Employee Wellbeing Clinic reports on symptomatic staff, and self-reporting from healthcare workers who are symptomatic or exposed to patients or sick household members. With this information, the IPC can immediately identify the areas in the hospital with confirmed cases of COVID-19 and initiate contact tracing. One confirmed COVID-19 case triggers an outbreak investigation by the IPC. Contact tracing of exposed healthcare workers is done in coordination with the unit managers and department heads. We found out that the risk exposure assessment done through a questionnaire sent to the healthcare workers using Viber messaging app was an efficient way to get information rapidly during investigation. The IPC officer documents all responses and determines exposure risk of the healthcare worker based on the algorithm for determining risk exposure and management of healthcare workers. We developed an algorithm based on the US CDC guidelines for healthcare worker exposure. We categorize healthcare worker exposure as low risk, medium risk, or high risk based on the duration of contact as well as PPE used by the patient and the healthcare worker during the interaction. Healthcare workers with low to medium risk exposure and without symptoms could continue working in the hospital, but were always required to use face masks and to do self-monitoring. Those with high-risk exposures, even if asymptomatic, were tested. All symptomatic healthcare workers, regardless of exposure risk, were tested. Healthcare workers who tested negative for COVID-19 and remained asymptomatic were cleared to return to hospital duty. Those with negative RT-PCR results, but who were symptomatic, were only allowed to return to work 7 days after resolution of symptoms. Healthcare workers who tested positive for COVID-19 and who were asymptomatic or had mild symptoms were advised to go on strict home or hospital quarantine. Repeat RT-PCR was done on day 15, and those with negative results were cleared to return to work. Healthcare workers who had persistent positive results continued quarantine and were retested after 7 days. Healthcare workers with confirmed COVID-19 who had fever or pneumonia were admitted to the hospital for management. All healthcare workers with fever, respiratory symptoms, or diarrhea, even without a known exposure, were tested. Management followed the same algorithm of healthcare workers with exposure to COVID-19 cases. Among the 1,551 healthcare workers who were tested for COVID-19, 144 or 9.3% were confirmed to be infected. Majority of infected healthcare workers were from the nursing service, followed by doctors, auxiliary staff, and staff from the diagnostic centers and pharmacy. 53% of healthcare workers had symptoms, while 47% were asymptomatic. The test positivity rate was higher for symptomatic versus asymptomatic healthcare workers, but this was not statistically significant. We were able to determine risk assessment for 1,864 healthcare workers. 13.6 had high risk exposure, 22% had medium risk exposure, while 64% of healthcare workers had low risk exposure. Among those tested, the positivity rate was significantly lower for the low risk exposure relative to both medium and high risk exposure. Of those infected, there were more females, and the average age was 36 years old. 68% had symptoms, although majority of the infected healthcare workers had mild symptoms. 1/3 were admitted to the hospital, of whom 14 had pneumonia by imaging. 3 healthcare workers were admitted to the ICU. All 3 had exposure outside the hospital. One of them expired. This was an 87-year-old physician who was admitted for pneumonia and had rapid and severe course of COVID-19. Our investigation also revealed that healthcare worker infection in the COVID units only accounted for 8.3% of all healthcare worker infections. There were 12 healthcare workers who got infected, 7 had exposure to a patient, while the remaining 5 were exposed to a sick household member or to a fellow healthcare worker. Most infections occurred at the ED. There were no healthcare workers in the COVID ICU who got infected. These findings mean that PPE protects healthcare workers from acquiring COVID infection. Approximately 2/3 of infected healthcare workers acquired the infection from a fellow healthcare worker or coworker. Only 14% identified exposure from a patient. Some healthcare workers could not recall any exposure. Although only 5% of healthcare workers had household exposure, the largest clusters of healthcare worker infections in our hospital started with asymptomatic staff who got exposed to a sick household member and who continued working while sick. We report this big cluster of healthcare worker outbreak in our hospital. The source was asymptomatic linen staff who was exposed to a sick household member and continued working while he was sick. The first group of healthcare workers who became symptomatic were orderlies who directly worked with the linen staff and who shared a small lounge area with him. Several healthcare workers in the unit became symptomatic, and all were confirmed to have COVID-19. Mass testing was done for the outbreak investigation. A total of 181 healthcare workers were tested, and 40 were confirmed to have COVID-19, including 16 healthcare workers who were asymptomatic. Another 3 healthcare workers belonging to other units, but identified through contact tracing, tested positive. As part of outbreak management, the unit was closed for thorough disinfection from April 6 to 18. No new case of healthcare worker infection was reported from the unit since April 13, 2020. Our investigation identified that healthcare workers do not consistently observe proper infection control measures when they are with their coworkers. Some practices such as crowding and inconsistent use of face masks in common areas such as the nurses' stations, pantry, lounge rooms, and call rooms contributed to the large outbreaks. Reminders and infographics were disseminated to remind healthcare workers to properly observe infection control measures in common areas. In conclusion, our experience at Makati Medical Center during this COVID-19 pandemic identified strategies to minimize infection among healthcare workers. Outbreak investigation, if done immediately and efficiently, is effective in identifying clustering of infections in the hospital. Broad testing strategies in units with clustering of cases is useful in identifying even asymptomatic healthcare workers and were found to be effective in controlling outbreaks in the hospital. Risk stratification of healthcare worker exposure can prioritize testing of healthcare workers who are more likely to have positive results. TPE protects healthcare workers from acquiring COVID-19 as evidenced by lower infection rates of healthcare workers assigned to the COVID units. Educating healthcare workers on the findings of investigation should be part of the process of outbreak management. Findings from outbreak investigation should be used to improve algorithms for determining risk exposure and management of healthcare workers. We hope that our experience at Makati Medical Center will help better understand how to prevent healthcare worker infections. I would like to acknowledge the hard-working frontliners of our hospital led by our medical director, Dr. Bong Javier. The data presented today have been meticulously collected by our staff in the Infection Prevention and Control Department and Dr. Marieta Glare of the Section of Infectious Diseases. The infographics were from Dr. Beryl Tan and MMC Marketing. Thank you very much.
Thank you very much, Dr. Kawili, for the very insightful experiences of Makati Med in handling healthcare worker-related infections due to COVID. So for the next portion of our discussion, can we now call on Dr. Celudo to share the experiences of the National Center for Mental Health in conducting their outbreak investigations among healthcare workers. Dr. Celudo?
Good morning. First, I would like to thank personally Dr. Mario Panaligan for inviting me to talk about what we experienced at the National Center for Mental Health, a DOH retained hospital specializing in mental health and wellness. Well, just to give you a short background, the National Center for Mental Health is occupies a 47 hectares, no? And the authorized bed capacity is around 4,200. However, the implementing bed capacity as of now is 3,500. Our current inpatient census as of May 30, as of May 31 is 3,082, and we do have 35 pavilions. And these pavilions are consist of the acute, chronic wards, including pavilions for pediatric population exhibiting behavioral changes, and also we do have a pavilion for medical, surgical cases, as well pavilions for the geriatric group. As of now, as to the number of personnel, we do have a total of 2,288 personnel, whereby the nursing service is around 1,064 doctors. We do have 278 doctors, and administrative personnel at 675. Now, during the COVID-19 pandemic, actually, we set up our triage during the latter part of February. And in the triage, we do screen all the visitors, including healthcare workers, prior to reporting to duty at their designated working areas. And also, we do, aside from thermal scanning, we do a short history. If ever there is a history of travel or a history of contact or exposure to a COVID suspect or a COVID confirmed case. And the general policy that we implemented is that uh, there will be restrictions or of entry of visitors, including relatives of patients. Likewise, there were suspension of OPD, elective surgery, and dialysis clinic services. And then we identified Pavilion 7 as isolation area for COVID confirmed, probable, and suspect cases. And then as for the healthcare workers who were identified as confirmed cases, we facilitated their transfer to COVID designated hospitals by the Department of Health. However, they do have options, no? Because majority of our healthcare workers that became COVID confirmed cases opted to choose home quarantine rather than be admitted at designated COVID hospitals. Now, I would like to show you our COVID-19 updates as of May 31, 2020, as of 12 noon. This is May 31. As for the confirmed cases, for employees, we do have 85 confirmed cases, whereby 69 of our employees have fully recovered. And then for our inpatients, we do have 36 confirmed admitted inpatients, and 17 admitted inpatients have fully recovered. As for the number of deaths, for employees, majority of our employees only exhibited the mild symptoms for COVID. However, we do have two healthcare workers. One is a nurse who has a comorbidity, and also the other one is a doctor who were admitted in private hospitals. But as of the present, they were discharged and reporting now for duties. As for the admitted inpatients, we registered the 15 deaths. However, 7 are confirmed cases. Only 7 are confirmed cases, and 1 is a probable COVID case, and 7 suspect COVID cases. And this is for the admitted inpatients. And our total hospital beds implemented is around 63. However, the total hospital beds occupied as of May 31 is 66, with 51 or 77.27% are COVID-related cases, and 15 or around 22.73% are non-COVID-related cases. So our occupancy rate as of May 31 is 104.76%. And this is the breakdown of our confirmed healthcare workers. We have 55 nursing personnel, 14 are doctors, 1 psychological personnel, 5 engineering personnel, 6 administrative personnel, and 4 dietary personnel. As for the number of employees that have reported back to work, we have 607. So now, actually, what is ironic is that our index case was a nursing attendant, no, assigned at Pavilion 28. This is a Geria ward, no. The age group, no, belongs the ages of the patients confined at Pavilion 28 range from 60 as the youngest and 77 as the oldest. So our index case, the nursing attendant, the history was this, no? The nursing attendant reported to work last March 13th. That was her last duty for that particular pavilion. And nobody knows, no? Nobody knew that this particular attendant was COVID positive. We only learned about it when she went to the triage to report that she is COVID confirmed case. So what we did is that we conducted an outbreak investigation at Pavilion 28. First, no, we verified the diagnosis. Yes, we confirmed that the nursing attendant, who was our index case, no, based on the hard copy of her result, was COVID positive. So we did verify the diagnosis of the first 7 cases that were transferred to Pavilion 7. No? This was the identified isolation area for COVID suspects, probables, and confirmed cases. And these first 7 cases were admitted from March 18 to March 25. They only complained of fever. However, chest x-rays done to these patients revealed bilateral pneumonia. And then the swabs, the PCR swabs of the first 7 cases turned out to be positive for COVID. So we were able to confirm that there was really an outbreak, COVID-19 outbreak at Pavilion 7. So what we did next was to alert top management. We also alerted the local government unit for efficiency, collaboration, and also for availability of resources. And then we did apply the case definition by DOH and WHO. And the definition should specify which patients, in this case, our geriatric patients, and which pathogen or type of infection. They were all positive for COVID-19. And when the date of symptoms onset was, it started March, we had admissions from March 18 to 25. The 7 first confirmed cases, COVID cases. And they were all confined at Pavilion 28, our geriatric ward pavilion. So we did, because of this, we did case findings as well, active contact tracing. No? So we requested for all patients of Pavilion 28 to undergo CBC, chest x-rays, including swabbing. Because as we all know, psychiatric patients, no, our patients are kind of unique in the sense that we all know that there is an impaired cognitive function. No, if you're dealing with psych cases, there would always be late detection, late diagnosis, because they cannot discern. No, these patients would never discern whether they are sick or not. Majority of them would not complain unless the vital signs would show, or there is the healthcare workers would observe that many of them, or they are not eating. That's the only time that we can appreciate, that we can discern that the patient is sick. So what we did, yes, we talked with their assigned with their doctor and reviewed their records, the comorbids present among these patients. Majority of our geriatric patients, about 70%, have comorbids such as hypertension and diabetes mellitus. So again, we have identified that 7 of our patients, from March 18 to March 25, geria patients had COVID infection. Next slide. So it's confirmed that it was the nursing attendant who infected the first 7 confirmed COVID cases at Pavilion 28. Then from April 1 to 7, another 4 geriatric patients were admitted with the same complaint, and all of these patients turned out to be COVID-19 confirmed. So what went wrong? So we did an infection prevention and control risk assessment at Pavilion 28. And we found out that during those times, there was breaches in IPC protocols, There were no wearing of appropriate PPEs, like the wearing of masks, and also the physical distancing, and also the patients, naman our patients, there's also a problem when it comes to hygiene. So we recommended the following infection prevention and control measures. Number 1, we did submit a report to our medical center chief that indeed there were breaches in IPC protocols. So the number 1 recommendation was to strengthen infection prevention and control measures anchored on hand hygiene, wearing of appropriate PPEs, physical distancing, isolation precautions, environmental cleaning and disinfection. And also regular health education on IPC among healthcare workers assigned at Pavilion 28. And we also did identification of high-risk areas at the National Center for Mental Health. And next is to limit the movement of healthcare workers, as well the movement of our inpatients. And then we also did a combination of expanded testing with that of PCR, and then correlated clinically the results. And then another recommendation is for the establishment of molecular laboratory and isolation facility with minimum requirements. And then to follow up, no, after the investigation, we have to monitor if they complied with our recommended IPC measures, and ongoing surveillance may be indicated to determine if outbreak is over and the prevention and control measures were effective. So this is my first line graph, no? The number of COVID-19 confirmed cases at Pavilion 28. It started March. Take note that I think I stand corrected. We had 9 confirmed cases from March 18 to 25. And then April, we had 2 confirmed cases. And the rest of May, no, it's 0. So I can conclude that indeed we were able to flatten the curve. And we also did rapid antibody testing for Pavilion 28 patients. And these were the results. Out of 39 inpatients, 18 were IgG positive, 1 was IgM, IgG positive, and 20 were negative. So I think that was my last slide. Thank you.
Okay, thank you very much po, Dr. Saludo, no, for outlining the step-by-step process your institution took into investigating the healthcare worker-related infections. So now, we can proceed po to our open forum, so our question and answer portion. If you would have any questions po, you can either input this into the Q&A box within the Zoom chat or through the Facebook Live comments. We will be screening through the questions. And we would like to invite all our speakers to answer. Dr. Kawili, Dr. Saludo, Dr. Arevalo, and even Undersecretary Kabutahe if she would be available po to answer. So we are now open for this portion. A few questions were asked already and have been answered by our speakers. So I think one question which was answered already by Dr. Kawili. The question was, are exposed asymptomatic, medium, and high-risk zoning healthcare workers awaiting the results of their PCR allowed to report to work? Or are they supposedly isolated at home until the results are in? So maybe we can get a DOH recommendation and as well as the practices of Makati Med and NCMH. So maybe Director Arevalo, would you have any recommendations on the side of DOH for the work schedule of of healthcare workers upon being tested?
Doc, our protocol on this concern is that one, our testing priorities are, we have grouped them into subgroup. Group A for those health workers who are symptomatics. They need to be tested at once. And as we have said, we need to conduct screening before every shift of our healthcare workers, and that when they are screened, we determine whether there are those healthcare workers who have been sick for the past 14 days, or have they traveled in areas with local transmission, etc. That's putting them high risk to have the infection. So when you have that risk exposure assessment, you now classify whether these healthcare workers can be sent home for their home quarantine, the 14-day home quarantine, or if they cared for a COVID-19 patient, a confirmed patient, they should also undergo strict home quarantine or referred to a facility, a temporary treatment and monitoring facility while awaiting for the result. And should there be should the result are positive, then they are advised to they are monitored by our IPC perhaps or disease surveillance officer of the hospital, because if they become severe or they have their manifestations, from asymptomatic to symptomatic, they are referred to appropriate facility. Like for mild symptoms, they can be in a quarantine, in a temporary treatment and monitoring facility. If they are severe, they are supposed to be referred to a COVID hospital. Okay, and then we do not wait for the testing to be released, the result of the testing. Immediately, we should have a recommendation to our healthcare workers appropriately kung sila ay i-quarantine ba for the 14 days while awaiting the result, or if they are symptomatic, they are admitted depending on the severity of their manifestations while awaiting results. Now, it's important to inculcate to our health workers that they should tell us their current condition, because in the health facility that we visited, there were health workers who were sick but were not or did not divulge that they were sick during that time. So they continued to report to the facility, probably the cause of the spread among healthcare workers. So meron tayong mga symptomatic na during the screening, hindi nila sinasabi na kami ay symptomatic. So that might be probably one of the causes of the spread among healthcare workers.
Thank you, Director Arevalo. Dr. Kawili and Dr. Seludo, would you like to share your experiences within your institutions with regards to this question?
Okay, this is Dr. Kawili.
Yes.
I think I answered already the question in the chat box. So currently in our algorithm for asymptomatic high-risk exposure, the healthcare worker is tested and they are requested to be on strict quarantine pending the results of the tests. So we are able to have the results within 48 hours. Before, it took us several days to get the PCR results, but fortunately now, the turnaround time is much faster. So we are able to do that. But of course, that really depends on your facility, based on the findings of your outbreak investigation. So from our outbreak investigation, it looks like even medium risk exposure have the same positivity rate as high risk exposures. So we will now be revisiting our algorithm. And since we are able to also recommend testing for medium risk exposures, even if they're asymptomatic, and wait for the results before they are cleared back to work. Thank you.
Thank you. Dr. Seludo, how about in NCMH po?
Well, this is my personal experience at National Center for Mental Health among healthcare workers who are COVID confirmed. The problem is that there is a delay, in the reporting to work, primarily due to delays in the release of the swab test. And aside from that, we usually require them to have a 2 negative test prior to reporting to duty. So, and also I discovered that aside from the delays in the release of the PCR test, the repeat PCR test, sometimes other employees would tell the triage that they have another exposure, not only once, but twice exposure to a family member or to a coworker. So another swab will be requested again. So sometimes it takes them 2 months to report, no, for work.
Okay, thank you po, Dr. Celudo. I guess in line with this question, there was another question po on the recommendation of testing for your asymptomatic high-risk healthcare workers. How often should we be doing this po? No? Dr. Kawili, would you like to answer?
So we don't do regular testing outside outbreak investigation. We only test healthcare workers if they have exposure based on our algorithm or if they have symptoms. Other than that, we have not conducted regular testing among our healthcare workers. But as soon as our Department of Health recommends that we do this, then we will comply.
Thank you, Dr. Kawili. Maybe Director Nap or Yusek Kabutahe would like to input po on the recommendation for this.
Dr. Mantaring. Actually, we have grouped our healthcare workers to be tested as to subgroup A, B, and C. The subgroup A, which are who are our priorities, are the healthcare workers have cared for, live with, travel with, who are asymptomatic. These are our first priority because we have, as you know, the limited capacity of the nation to do in mass testing. So we have prioritized our healthcare workers to be tested. Perhaps Yusek Kabutahe can add to that.
Thank you. Moving on the statement of Dr. Knapp, we have 4 groups who are prioritized for what we call expanded testing. Yung sinabi niya is the patients or healthcare workers with severe critical symptoms, relevant history of travel or contact. And then next are those with mild symptoms. The next ones are with and considered vulnerable. So kung yung mga may comorbidities, yung mga may senior citizen, ito yung mga pregnant, these are our priority for second group. The third priority are those with mild symptoms, and then the fourth are those with no symptoms but have history of travel or has history of contact. As a general rule, tama yung sabi ni Dr. Kabili, they usually prioritize those who, if there is an outbreak. So may kaso na, may exposure. So they do the testing. As a general rule, sana kung meron tayong available na resources, we would like to have the health workers, ang minimum interval between tests should at least be 1 week. Because it gives you, it's the incubation period and the time of the manifestation. So as a general rule, before you do another swab, dapat may 1 week interval. Kaya ang sabi ni Dr. Sa National Center for Mental Health, iba-iba yung exposure. Kung iba-iba naman yung exposure, di ba, you give at least 3 to 5 days before you develop symptoms. So at least may 1 week na interval between swabs. Thank you.
Thank you po. Thank you very much. Okay, there's another very relevant question here with regards to the use of the clarification on the use of RT-PCR and rapid testing as screening for healthcare workers. So it's a very hot topic po now. So maybe we would like to comment po on the use of this, especially for the healthcare worker subgroup po. Maybe I can direct the question po muna to Dr. Celudo.
Actually, I am using now the rapid antibody testing among our psychiatric inpatients because as I mentioned earlier, our patients are kind of unique in the sense that they don't really complain. So, so to have a clearer picture, we did mass testing for our identified high-risk areas. And what are these high-risk areas? The Geria pavilions and the forensic. We do have a court cases pavilion. And aside from that, the emergency room and the assist area whereby patients usually admitted here usually comes from outside. So these are the identified high-risk areas. And so far, we have a clearer picture, no? To just get a clearer picture of whom amongst our patients, no, are at a higher risk to acquire this COVID infection, because majority of them are asymptomatic.
Okay, thank you, Dr. Saludo. How about po from the side of DOH maybe? Any comments po on the use of rapid testing uh, for screening of healthcare workers prior to return to work?
Dr. Kabutahe, Angelo, the gold standard is RT-PCR for screening, no? Because you want to determine whether they have the infection. The rapid diagnostic tests are antibody tests. That means it will detect whether you have already the antibodies. So it will determine a previous exposure and now you are developing antibodies. In our algorithm, there are statements or there are conditions when you can do rapid diagnostic tests. Although we know that many of the things about COVID are evolving, so we're now trying to update our algorithm. But basically, it's important to know at what stage the patient is. No, if we want, as sa National Center for Mental Health was saying, monitor na natin yung dati nang exposed. So it's not really the antigen antibody may be good to determine whether the health worker has already developed antibody. What is important for this rapid diagnostic test is number one, they should be in the list of the approved by the Food and Drug Authority, Food and Drug Administration. Because we know these are new technologies, we are not able to do some testing. So what the FDA does is to look at the papers, whether they have passed screening and all the tests abroad. And these are submitted to the Research Institute for Tropical Medicine to validate the sensitivity and specificity of this rapid diagnostic test. And as we have emphasized, it's important that you correlate the symptomatology. Hindi pwedeng RDT lang, tapos magtitignan mo na positive, negative. You have to correlate if it is an IgM, IgG, ano ba yung negative, positive, may algorithm din yan, and connect it to the patient. Kung may nararamdaman siya o wala siyang nararamdaman. And then it's a little technical, but you can look at our issuance on expanded mass testing para ma-compare natin what is an IgM, what is an IgG test. Kasi kung minsan, they just combine the two, you need to really separate. Ano ba yung result ng IgM? Ano ba yung result ng IgG? But we have allowed the use of rapid antibody tests as adjunct testing for COVID among symptomatic patient with relevant history of travel or exposure. But as I was saying, we are now trying to review the protocols if we can make some appropriate changes based on developments and experience. Thank you.
Thank you po, Yusek. There's one question here, um, maybe very specific po, but maybe we would like to ask Dr. Kawili to answer this. Any recommendations regarding the passages of healthcare workers and the transport of COVID positive patients to and from an operating room facility with a single entry point? So I guess the context po kasi is there are also small hospitals po no with only single entry points into their OR complex. So any recommendations po from the FIX or the PISMID with regards to that?
Okay. I know that the recommendation of our societies is to have a clear traffic in the hospital, like, from the hot zone to the cold zone, from the dawning to the doffing. So that should be very clear. But in case there is no space for, all this traffic in a hospital, you can actually um, innovate. So it's very important that though the healthcare workers coming from the COVID units doff before going out of the COVID units. So that should be followed. So anyone bringing a patient to the OR should already have, removed the PPE from the COVID units. Or you can also identify a staff who will receive the patient outside the COVID unit. So the staff in the COVID unit won't have to go out and bring the patient to the OR. In the OR, you can also identify staff who will receive your patient from the entrance. And then, all these innovations will prevent healthcare worker contaminating the environment in your areas. The nurses can help, When you develop these protocols in your hospital, you talk to your nurses because your nurses can help you in determining the proper flow of patients from a COVID unit and to a clean area.
Okay. Thank you po.
Dr. Tarin,
Yes po, Dr. Ireba.
Doc, uh, um, as of now, the secretary introduced the 10-point strategy to reduce mortality of COVID and those mortality unrelated to COVID. As of now, we have recommendations on establishing pathways, a different pathway for the non-COVID patients and a pathway for COVID patients. Siguro long-term plan of our healthcare facility is that for now we can innovate, but long-term we are now into the new normal that we would like to also evolve from having a new normal with zoning in the hospitals, as well as the separate pathways for patients with COVID and non-COVID. In fact, we are also factored in the PPE use for even for those elective surgeries, like also cesarean section, that they will also be donning PPEs that is appropriate, rather than the old practices that we have, that we only don the surgical PPEs that we use pre-COVID time. So long term, we should also evolve to the new normal, where in the hospital will factor in their improvement of the IPC, the separate pathways, as well as in the ones we the ones we recommended in the doning and the dofing, wherein there is a 3-tier rooms, so that whatever is contaminated in the hot zone will not be introduced to quote unquote the clean zone.
Thank you, Director Nap, for clarifying that rin. So I guess, yun nga po, important sa ating mga community hospitals, yung really establishing that separate pathway for COVID and non-COVID patients and adapting to this new normal, as they say po. No? So being more precautious po talaga. Maybe just a few more questions na lang po. There's one question on manpower issues. So we recognize po na there are some hospitals with the lack of manpower, and however their staff are required to undergo quarantine or isolation. Can the institution mandate high risk exposed asymptomatic healthcare workers awaiting PCR result to report to work? Maybe I can direct this question po uh, to Director Arevalo from a DOH standpoint. Can the
The,
yes po?
the question was that can a health worker exposed to a COVID-19 patient
Yes po. Can
While waiting.
yes,
can
due to the lack of manpower within some hospitals, can an institution mandate an exposed healthcare worker awaiting PCR result to return back to work?
yeah, I think that can be done. In fact, in some areas, the institution provided lodging houses or accommodation to those health workers directly caring for our COVID-19 patients. So uh, while they are at work, probably they only need to have that working arrangement that these workers have considerable time to rest, and that special work arrangement should also be uh, established in the hospitals. Our Chinese specialists said that or recommended that there would be shorter time for the shiftings, and then during the nighttime longer. But while awaiting test results, even they are high risk, asymptomatic, they can continuously work, no? As long as they are screened daily, every shift, and they are monitored for any symptom. So we appreciate that some institutions have their own laboratory to test, that the turnaround time is shorter so that they can continue work even if they are directly caring for the COVID-19 confirmed cases. And I would agree with Dr. Agkawili that the strict compliance to IPC as well as the observance, the strict adherence to the observance of the proper donning and doffing will be observed so that we prevent transmission.
Okay, thank you po, Dr. Arevalo. We have a question po. Are there any observations on the behavior of confirmed COVID cases clinically well 14 days later? Any observations on the behavior of the confirmed COVID cases who are clinically well 14 days later? Their I guess in terms of their swab test and clinically. Dr. Kawili, maybe you would like to, or Dr. Saludo, you would also like to share any insights po with regards to this question.
So majority of our healthcare workers who had a follow-up RT-PCR test had a negative test by day 14 or 15. But there's really a proportion of healthcare workers, especially those infected earlier during the outbreak or the surge of cases of patients in Makati Med, who had a positive RT-PCR results beyond day 14. But we all know that the WHO released the latest recommendations on when to lift precautions. And we will be looking forward to changes in our recommendations from, of course, our Department of Health and our societies. If we will be changing, the quarantine period for our healthcare workers, and if we really need to do a repeat PCR test rather, for those who are clinically improved. So, but what we are currently doing right now is to test them again on day 15. And if they are negative, then they are cleared to work. So just one test. If they still have a positive test result, we retest them after 7 days. But as we all know, the COVID is ever changing, very fluid. No? So these recommendations can, of course, change based on latest developments and recommendations from DOH and the World Health Organization.
Thank you, Dr. Kawili.
Well, as for our healthcare workers who turned out to be COVID positive, my observation is this: majority of them still are after 14 days, no, and then a repeat swab was done, still positive. Only one or two healthcare workers gave a negative result. And then there was even one healthcare worker from our institution who was confined. And then almost always he was positive. And then after 1 month of confinement, he had 2 successive negative tests, only to be informed that the last test done to him turned out to be positive. So this particular healthcare worker was really puzzled.
Thank you po, Dr. Saludo. I guess we have room for one more question. This is from Dr. Dante Morales. Can you comment on Singapore's practice of not doing swab test for clinically well confirmed COVID cases, but instead just keeping them quarantined for 21 days? Maybe Dr. Kawili or Dr. Saludo would also like to comment on these.
I think, Dr. Morales, the changes that will uh, be released by societies in the next few days will actually show that we can do either the symptom-based or the test-based approach to clearing healthcare workers back to work. So if we have access to testing and we know that the turnaround time is shorter, we can do test-based. But for symptom-based, we might be even clearing our healthcare workers earlier than 14 days, definitely earlier than 29 days. So based on the symptom-based approach for clearing healthcare workers, if they are asymptomatic and they were at least 10 days from the start of of their symptoms, and they have 3 days of uh, continuous asymptomatic period, and they don't have fever, and they can be cleared for work. So we will be, anticipating that these changes will be part of our recommendations for clearing healthcare workers, and it might, of course, change our current algorithms on how we clear confirmed COVID-19 healthcare workers back to work.
Dr. Saludo, would you like to add anything?
Well, based on my experience here at the National Center for Mental Health, I would like to tell Dr. Dante Morales that somehow, if you are identified to be COVID confirmed, there is a sort of stigma attached to it and also discrimination. It is okay with the healthcare worker. It would work, no, for the healthcare worker. However, the co-workers, no, the problem will be the co-workers, because my observation here, the co-workers of a COVID positive would always look for hard copies that this co-worker is negative already. So that would be the problem, the stigma, and there is some sort of discrimination. I've seen that here at NCMH.
Thank you, Dr. Saludo. Yes, that's a very valid point po, no, the discrimination and stigma against our health workforce when it comes to being at high risk exposure. Would
I
USEC
just add, yes,
Yes po,
thank,
yes.
thank you. I will agree with Dr. Kawili. As I have mentioned earlier, there are developments that are occurring, and she's correct that we have a technical advisory group that is reviewing the recommendations of the society, what we have used in DOH is the PSNID, Philippine Society of Microbiology and Infectious Diseases guidelines. And yes, we might we may really do a symptom-based or a test-based determination whether to allow the health worker to come back to work or not. But even before, we have always left it to the institution. Dr. Kawili will has been a witness to that we ask the institution, as she has very well described in her algorithm, to be the ones to assess the risk, kung pababalikin nila, saan ba nila idadalhin, and then you see that if they are donning PPEs properly. So from the beginning, we really left it on a case-to-case, while we have general guidelines, it is the hospital, the institution itself, who will determine saan ba siya exposed na area, high risk ba siya, are her services needed, can she be relieved, somebody can take over, or ang kagaya ng ginawa sa San Lazaro at one point was hindi nila pinaalis yung health workers sa special area na lang for 2 weeks. So they were the ones rotating without going out. So we leave it to the chiefs, and especially kaya nga meron tayong mga infectious prevention and control teams in the hospitals who go on a case-to-case and institution-by-institution basis. Salamat po.
Thank you po, Yusek Kabotahe.
Commentary.
Yes po, Dr. Arepan.
If I may add, yung mga na-quarantine na mga healthcare workers, sabi ni Dr. Uy, ang sinasabi is that they are to be assured, or they usually look for documents saying that they are going back to work. Kung yung mga naka-quarantine, sa policy, the quarantine officials can provide a certificate of completion of quarantine. And those who have been sick, the attending physician can issue a health certificate that they are already they are already cleared, or they are already healthy to get back to work. No, of course the laboratory results that we require prior to resumption of work. So if they need documents for them to be assured that these co-workers are already healthy and can return to work, these are documents or relevant documents that can be presented. However, the best thing to do is for the IPC and the management to continuously educate and provide information, correct information to our health workers, so that in the event that they have health workers infected with COVID returning to work, the stigma is somehow appeased. So there should be a constant reminder to our health workers that we should be the first one to be the examples of non-discrimination and non-stigmatization of the disease. But we do this after we have provided the facts to our health workers. So importante na continuous yung education ng ating healthcare workers as the disease evolves.
Thank you, Dr. Arevalo. Yes, that's very to minimize the stigma. I think that could help po by providing the necessary documents po talaga. Okay, so that ends our session for today. We have reached 12 o'clock. So any last words po from our speakers? Maybe we can start with Dr. Kawili, and then Dr. Seludo, Dr. Arevalo, and then Yusek Kabotahe. So Dr. Kawili, any last words po? You're still on mute po, Dr. Ko.
Thank you again for this opportunity to share our experience at Macarthur, and we hope that we were able to share important information that can be used by our colleagues in their own hospitals. So I also enjoyed the presentations of Dr. Arevalo, Dr. Kabatahe or Yusek Kabatahe, and Dr. Segudo. I also learned from their updates and their experiences in their hospitals. Thank you.
Dr. Celudo.
Just stay safe and healthy by always wearing your mask and observe always the physical distancing. Thank you for inviting me.
Dr. Arevalo.
Maraming salamat, Dr. Mantaring. The Department of Health wishes to convey our thanks to the organizers as well as to the PCP, our resource persons. It was very productive. It was very informational. And we hope to have such meetings every now and then for us to be able to monitor infections among our health workers and that we provide assistance the best we can. Maraming salamat sa pag-share po ng mga experiences because from this we can perhaps review our protocols on IPC and we hope that when we are done with the harmonized tool for the hospital assessment, we can share it with you and the hospital can do their self-assessment periodically to ensure that the IPC measures are being strictly adhered to. So God bless us all. Maraming salamat po.
Thank you po. And finally, Yusek Kabutahe.
Maraming salamat po sa inyong lahat. We salute the organizer and we salute our frontliners. Kahit sinasabi natin na marami silang mga hindi nagawa, mga lapses, there still are frontliners who have committed to serve during this time. Pangalawa, sa discussion nakikita natin na may networking talagang nangyayari between private and government, not only in the cases but also in the laboratory. Number 3, ang pinapakiusap ko lang natin kasi we are challenged by the reporting system. Sana po lahat ng ating mga encoders sa ating disease reporting units ay kompleto yung data. Naghahanap po kami ngayon kung saan yung address, kung ano yung mga contact number, pati po sa mga laboratory. And a short note on the bakit when we have RT-PCR, kagaya sabi ni Dr. Celudo, 1 month na nagpa-positive pa, tapos nag-negative, nag-positive. We look at it individually. Number 1, baka may vestiges pa, may mga naiiwan pang virus load, pero hindi na siya infectious. Pangalawa, negative pero nag-positive, contaminated, that can also happen, contaminated yung sample, and we look at baka naman hindi lang contaminated yung sample, na-expose din ulit siya. So we have to look at it case by case. Maraming salamat po sa inyong lahat.
Thank you po, Yusek. So that ends our session for today. I'd like to inform everyone that recordings of the session can be accessed through the official Facebook pages of the Philippine College of Physicians and Department of Health, as well as the official YouTube channel of the PCP. I would like to congratulate and thank all our speakers and attendees for your time and effort to deliver this very fruitful and scientific discourse. Thank you to the PISMID and the Philippine Hospital Infection Control Society for partnering with us for today's topic. And we hope to continuously provide these feedback and learning channels for us healthcare workers. And until our next session next Monday, which covers dengue in the time of COVID-19, take care and stay healthy and safe to everyone. A pleasant morning to all.
Thank you.
Thank you po.